Mm-mm. No, no.
If everyone could take a seat, we'll get the next session started. All right, so I'm Ryan Selly, one of Dr. Stover's partners up at Northwestern. I just want to thank Ben Coons for putting this all together. Can you guys hear me? I just want to thank Ben Coons for putting this all together. This is really his brainchild, and excited to be a part of it. So this next session is hip preservation surgical techniques, and Rob Wetzel will get us started with PAO surgical approach, how best to protect the LFCN and approach the ischium.
Thanks, Ryan. When Ryan and Ben asked me to talk here, obviously I felt very honored, but I said only if I can talk about the lateral femoral cutaneous nerve because people care about that so much. Can you load that talk up? Was there? All right. No pressure. Mm-mm. Okay. Like Ryan said, I'm Rob Wetzel from Cleveland, Ohio. Open hip preservation surgeon, do mostly trauma, PAOs, and totals. So we're going to be talking about lateral femorocutaneous nerve dysfunction after PAO. So there's a long list of things that could happen with PAO. I think we all are in this room. We're doing this as a pretty common procedure, but I often have to remind myself it's a big operation. And when you have those talks with patients, you usually have to go through a list of things that potentially could go wrong. And the one thing I say that's almost always going to happen is you have some kind of numbness on your lateral thigh. So I think it's important that we talk about this. Probably one of the most common minor complications following PAO. And I think that's why it gets sort of brushed under the rug. At these conferences like ISHA and local conferences, I often talk to people about, how they talk to patients or what they say. And there's a lot of just like, hey, it's cost of admission. This is exactly what happens every time. You really can't do anything about it, but it doesn't really affect their function. Well, a lot of studies have come out to show that that's true, that it is very common, up to 3/4 of the time right after PAO in that acute setting. But even at a year, about half the time people are having some sort of lateral femorocutaneous nerve dysfunction. And what's been interesting is that multiple studies have shown that it doesn't affect outcome score when it talks about PROs and functional outcome, but a lot of emerging studies are showing that it does affect mental health and other negatively impacted day-to-day function of the patient, not so much the function of their hip, but lifestyle function. So just to get to some of the basics, the anatomy, it originates from L2-3 from the dorsal lumbar plexus and will go under the inguinal ligament and then up and over the sartorius. And oftentimes, if you've done this in trauma, you do an ilioinguinal approach, you obviously see this nerve every time, but you don't always see this nerve in PAO, which I think is some of the reason why it's a little bit elusive as to why this always happens. Is it a traction injury? Is the nerve cut or branches cut? How many branches? Is the travel of this nerve typical? Is there some atypical or barren anatomy? So this is just something that I'm usually always aware of, but definitely don't see it every time. And you can see that it arborizes significantly. So usually some, if not all of those branches, or at least some of those branches, are either stretched or damaged. This was always also something that struck me when I first started doing this operation, is that I was always sort of under the impression that the lateral femorocutaneous nerve had a small coverage zone. That is not true. And the first time you cut one and you talk to that patient how they feel, you understand that that's not true. That can go down the entire lateral, anterior lateral thigh, and sometimes even past the knee, which was really surprising the first time you'll see that. But you can see numbness down past the knee joint and even in the posterior thigh. And you can see this outlined here. What this usually causes in patients is this neuralgia. So that can mean a couple different things. that the skin actually feels painful, allodynia, numbness, also hyperesthesia, that bed sheet phenomenon you see sometimes in like complex regional pain syndrome where I can't put a bed sheet on my foot or my leg. It's like so hypersensitive, or even when water hits it in the shower. In bad cases, you can hear patients complain for that. Or sometimes just mild irritation. Every now and then it feels like pins and needles. Not all the time when I do such and such. And then you got to think about potential treatment options, which we'll talk about all the way at the end. And we talked about the distribution, where it could be a small area near the incision, or it could extend as far down as the lateral joint. So can this be affected by exposure? I think one of the challenges of this talk was trying to say, well, how can we actually prevent this? Because I can tell you 100% I have not perfected protecting this nerve. But I am aware of it and try to think about it each case that I do. And I've done a multitude of different incisions over the years, whether that's a more traditional extensile vertical incision or a C-shaped incision, or even something like a bikini line incision, which I've changed my wording to concealed by clothing because most of my patients are teenage females that present with their father. So I'm not going to talk about their bikini line. But yeah, so something more horizontal, does that really actually protect this nerve? So when is it injured? And I think the ischial exposure is probably the most common time that it's injured, and the initial fascial exposure. Those are probably the two times that it's at most vulnerable risk. And why it's exposed during the ischial exposure, why it's exposed to being harmed, is because of the stretch you get from the osteotome at the end of your fascial release. That handle, the bar of the osteotome, is pushing right up against the nerve, and also from medial retraction, typically in the area of the ASIS. Most of my practice is scope PAO combos. So I have a partner that does the scope and I'll do the PAOs, and that's typically what we're doing. And we often talk about, does the scope increase the risk of this? Now, it's not all the time as combos. We do also a fair number of staged operations or sometimes isolated operations. I do feel that the scope compounds the risk. Your entry portals are in the area of maybe some more of the more distal arborized branches, but there is, I think, a compounded risk there. And what's really nice is that typically in someone after surgery, when you first see them and they have a little bit of numbness, they're like, yeah, it's numb right over the scope. And I'm like, I can't, it's my other guy. It's not me. I don't tell you. But there is some, I think, some area around those scope portals that definitely gets a little numb. Okay, so how can we protect it during that initial exposure and during the osteotome stretch? So when I first started doing this operation, I was doing a sartorius tenotomy. This is how I was taught. I've moved now to a anterior superior iliac spine osteotomy, but not a very large osteotomy that requires a screw. I'll show a video of that in a moment, but typically just a small wafer of bone that can help pad and protect that nerve during medial retraction. I think a Horder approach rather than a classic Smith-Peterson where your incision of your fascia is more traditionally lateral over the TFL muscle belly to help protect some of those more medial arborized branches is also protective. And then releasing your fascia distal and proximal. So typically the incision size I found in PAOs can be a little deceiving, whether it's a large or a big incision. These patients are usually very young and thin, and oftentimes, we heard this morning, hypermobile. So a mobile window approach where your incision is movable around so that you can get a little more distal depending on how you position your retractors or how you move the skin, or proximal to release both the proximal and distal fascia to allow for a little more excursion on the nerve without it being tight. And then should we dissect this nerve out? I mean, if it happens really in 3/4 of the time acutely and 50% chronically, should we be finding this nerve, seeing it, protecting it? I personally don't, but I think that's something we can discuss during the panel session. So the way I try to protect it, like I was saying, I do this distal fascial release, like a subcutaneous fascial release to help the medial retraction and then the ASIS osteotomy. And then I usually try to keep the hip in a slight amount of flexion, and we'll talk about this a little bit at lunch too, using this Guardian table, how I think that is very helpful to maintain the hip in a stable and steady position to protect the femoral structures and keep them lax, but also having the ability to adjust that leg to protect the posterior structures, mainly the sciatic nerve, during critical portions of the operation. So this is just how I do my ASIS osteotomy. I had a picture previously of where I tried at one point to make my incision more medial, more centered on ASIS, so that if I see that nerve, I can protect it and try to be more aware of it. Now I'm probably making my incision where 80% is proximal to the ASIS and 20% distal. We'll see if this video works. Okay. So no sound, but that's all fine. I'm happy to narrate it. So at this point, I have everything exposed where the inner table has been released with a cob, the distal fascial incision has been made, and I still have a tether right at the ASIS. So I said initially I was doing sartorius tenotomies But now you can see how horizontal the osteotome is and how small this piece of bone is. This little piece of bone, a little wafer of ASIS, and I'll show you how to repair it at the end, but it helps pad and protect the nerve medially. And at least in my own series, I've noted less nerve injury using this technique versus a tenotomy. And in the tenotomy, oftentimes I would see a splaying or a propagation of the fascia, like down in toward the inguinal ligament if you have excessive medial retraction, because there's no central tether between the external oblique and the sartorius. So this kind of keeps things together and the dissection a lot more clean. So you can see in this case, this was a recent case of mine where I stumbled into the nerve and it was perfect timing for this talk. You can see what it looks like just medial to the ASIS. And you can see the, I wonder if, no, I don't think the thing works. But you can see like this is the ASIS, osteotomy bent right here. So we're just medial to that during our medial exposure. And then to the right of the screen is distal. So you can see what that looks like. Here's another video of how I'm just describing in this particular case. I have that piece of the osteotomy already released and just kind of going over in this particular video how the retractor is padded up against that piece of bone. So you don't necessarily have direct contact between the retractor and the soft tissue that contains the nerve. We'll move along. Okay, so Ryan tasked me with the ischial exposure, and this is sort of the part where the nerve is probably most at risk. So this is how I expose the ischium. The hip is in a slight amount of flexion, which is probably contrary to what most people do, and external rotation to relax the sciatic nerve. I'll take my finger and put my finger directly on the inferior spine and use these curved Mayo scissors to open this path. Once I get my finger on the inferior spine and the fascia is released from the sartorius, I'll put those scissors over the femoral neck and under the iliopsoas tendon, which I think is probably what most people do. And then find the blind-ended pouch that ends there and then pop the scissors through and expose. And you can see that happen here momentarily. Perfect. So then the scissors come out and then your finger can pass all the way underneath. And then the same sort of thing with the osteotome. So I'll take my finger, try not to get a piece of my glove caught on it, pass the osteotome just under my finger to make sure that it's safe, and then get the osteotome anchored on the ischium. And this is what that looks like again. So the osteotome is now on the ischium, and I'm just at this point demonstrating the typical amount of stretch that I'm comfortable with and trying not to injure the nerve during this particular portion. So you can see on the fluoro, I'm anchored in the subcotyloid fossa, and now I'm just kind of feeling lateral, central, medial with the osteotome. In a moment, I'll kind of show you the resting tension that's most typical that I'll be comfortable with in this particular part right about here. So you have a little tension on the skin, a little stretch, and you're turning a horizontal, if you do the bikini, a horizontal incision into more of a vertical incision at this point, so there is a little bit of a transverse stretch there. But that's about the comfortable amount of stretch that I like to do. And if I have any more than that, I may extend the incision to help release that a little more and take pressure off. I'm just going to move on. Okay, so this is what it looks like with the scissors in that particular area, and then marching from medial, central, lateral to make that ischial cut during ischial exposure, and then about a 50-60% depth of partial cut there on the bottom. All right, and this is how I'll repair the small osteotomy with suture. Let's see if that plays. So there's a drill tunnel through the base of the anterior superior iliac spine osteotomy, just a 2 millimeter drill, and pass like a number 2 heavy non-absorbable suture through that. Then you'll see that that comes over very nicely here in a moment. And you can see what it looks like finished product where it's sutured back in place. So I don't have to worry about hardware traffic or additional screw or blowing that fragment up with another piece of hardware in that particular location. But that's sort of what it looks like there. Okay, so is this really a problem? So we talked about that early on. Well, there's a guy in Texas, I don't know if Harris knows this guy, but he literally advertises nerve surgery just after PAO. So it must be a common thing, at least. I don't know if is it your fault, Harris? This was like, I just searched this on Google. There's the first thing that came up, like nerve surgery after PAO. So I don't know. So it must be a problem. There you go. Send it home. So the Yamamoto group, there you go. Yamamoto group published this in 21, and this is what he showed on the first slide, that it's 3/4 acute and about a half at 1 year. But again, it didn't affect hip outcome, just the mental health part of the patient. The Mayo guys also published something similar, where there's no significant association with the symptoms of lateral femocutaneous nerve injury, the allodynia, burning, lack of sensation, and their outcome score. Okay, but then that same group went back in 24 and published again that the lateral femocutaneous nerve injury is high after approach to the PAO. And even as far as 3 years out with persistent symptoms, their real overall satisfaction with having the operation, their mental health is affected significantly. So I do think this is an unanswered problem. And I think that probably half our patients have issues with this particular thing. And then if that happens, what do you do now? Okay, so it's damaged. They're complaining. You're not a neurosurgeon, but you caused it. What do you do? You can start with, number one, your preoperative counsel. You know, the first time you have someone that has a really bad injury, you think to yourself, did I warn them about this? Did I talk about this sufficiently? So I always make sure that I talk to patients about it before. I'll treat people for 3 months, typically during and then 3 months after with gabapentin if they can tolerate it and they don't have a side effect profile that's unfavorable. To help nerve recovery during that time, you could also use Lyrica. Sometimes if my screws are near the ASIS or there's a big suture knot or something, I will take hardware out to try to do that and then maybe block the nerve at the time, which has helped a handful of patients as well. Or I'll send them to a colleague that does it under ultrasound, either block, and if it's successful, then maybe ablation. I have a really nice hand partner who's a micro specialist in peripheral nerves, and will do a formal dissection for me if patients actually need something like that as well. But that's typically where the treatment would go. There's a really nice set of recommendations that's been published by Professor Gans about how to protect this, and not just lateral femocutaneous, but all other nerves during PAO surgery, obturator, or sciatic. So it's a good read if you haven't seen that. So this is just sort of a summary. How can we help prevent this? Is it preventable? I don't know. I haven't, like I said, I haven't perfected that yet. Nowhere near. I think that you're probably always going to be sectioning at least a proximal branch of this, but some things you can do to help do that little ASIS osteotomy or any ASIS osteotomy to help pad the nerve from retraction. A C-shaped incision was recommended in those set of recommendations as one of the safest to help protect that. I still do the bikini line incision with more of a fascial release subcutaneous. And I think during the time of when you're manipulating the hip,